Hello, everybody. Welcome to the webinar. We're just waiting for people to log on. Okay. Hi, everyone. Welcome to the webinar today. This is the third in a series of webinars that the Association of Nurses in AIDS Care is presenting on PrEP. I see that people are still signing on, so I'm going to just pause for a minute. Okay, seems to have slowed down. So welcome today. Today's webinar, PrEP module number 3, is entitled HIV Risk and Prevention for Women. I am really thrilled to have Erica Aaron as our faculty today. Erica is from Drexel University in Philadelphia. My name is Carol Treston, and I'm with the Association of Nurses in AIDS Care. You will be eligible to receive continuing nursing education credit for attending today's webinar. At the end of the evaluation, there's some information, but probably more useful is after today's webinar, you will receive an email with a link, and that's when you follow that link, you'll receive a post-test evaluation and then a way for you to put in your information so that you can get your certificate for 1 hour of credit for continuing nursing education. Because of continuing nursing education, we want to inform you of the following disclosures. Erica Aaron has no actual or perceived conflicts of interest. Carol Treston has served as a Community Advisory Board member for Gilead, and this program is supported in part by a fund from Gilead Sciences awarded to ANAC. The learning objectives for today are that participants will be able to discuss issues related to the uptake of PrEP in women, describe what PrEPception is and how to use it in their practice if that's applicable. And the participants will also be able to list clinical guidelines and resources for establishing a PrEP program for women. Just a few seconds on housekeeping. For those of you who have attended before, you know that the participant lines are muted and that we encourage people to write in their questions in the questions panel on the dashboard on the side of your screen, and that we reserve time at the end for questions and answers. Please continue to write questions in throughout the session, and we will certainly get to them at the end. The other question that always comes up is, will these slides be available? And yes, that's part of the email that we send you at the conclusion of today's webinar. You'll get a PDF of the slide set. So here's our agenda for today. We're really going to do a really deep dive on PrEP for women. Erica is going to talk about HIV risk for women, PrEPception, PrEP in sexual health settings, and guidelines for clinicians. We'll spend a few minutes giving you some sources and resources for PrEP information, and then have time for questions and answers. Just to make sure we're all on the same page, here's a quick snapshot of PrEP. As you know, this is one of a series of webinars that we've done on PrEP. PrEP is pre-exposure prophylaxis for HIV prevention. It was approved for usage by the FDA in 2012. It really is the use of an improved antiretroviral treatment medicine for vulnerable people to take to prevent HIV. Currently, there is only one drug approved. That's Truvada, which is tenofovir and FTC. PrEP is taken as a once-daily oral pill. There were also CDC clinical guidelines released in 2014. And these guidelines list a lot of the evidence in the clinical trials, multiple clinical trials that showed the efficacy of PrEP across the board between 44 and 67% effective. But when we really look deeper at those in those trials who had good drug levels, the efficacy was greater than 92%. And you'll hear more about this in today's presentation, but PrEP requires HIV negative confirmation before starting and ongoing lab monitoring, sexual disease assessments, and good adherence education. So it's now my pleasure to introduce Aaron. Erica is going to talk about PrEP for women, stay negative and stay positive. Erica is a nurse practitioner and the PrEP Clinical Advisor for the Philadelphia Department of Health. In that role, she educates clinicians, staff, and the community about the benefits of including PrEP counseling in both primary and reproductive health care. She is an investigator on a multi-site study about PrEP for women, and she's also an investigator on a study assessing PrEP uptake in family planning clinics. In addition, she is an assistant instructor at Drexel University College of Medicine and has worked for more than 20 years in providing clinical care to women with HIV, specializing in PrEP and pregnancy. So it's really my pleasure to now turn the mic over to Eric Aaron, who will spend a lot of time digging deeply into PrEP for women. Eric, it's all yours.
Thank you very much, Carol. And welcome to this webinar, everyone. I thank you for your interest in this topic. So the name of my presentation is PrEP for Women, Stay Not Negative and Sex Positive. Next slide, please. So to start with some good news, the incidence of new diagnoses of HIV in the United States from 2005 to 2014 has shown a decrease in the incidence among women, a 40% increase in all women in the United States, who have 42% among African American women, a decrease in 35% among Latino women, and a decrease of 30% among white women in the United States. Next slide. And we know that women, the primary mode of transmission is heterosexual transmission, showing 87% of all women who have HIV have that this is their mode of transmission. And we also know that there's a lot of disparities in HIV in this country, also shown among women, where in 2014, of women who have HIV in the United States, 61% or close to 62% are African American, and 16% are Hispanic and Latina. Next slide. So one of the reasons there's a higher risk among women of color is that there's a higher vulnerability despite practicing same sexual behavior as other women, including condom use and number of partners. But the fact that women of color live predominantly live in neighborhoods with high prevalence of HIV includes that their sexual networks have a higher risk of getting HIV. So that the women in these communities face a greater risk of HIV acquisition with each sexual encounter. Next slide. There's a full spectrum of interventions to prevent and treat HIV at this point. We're living in a time of great optimism for HIV prevention, where we can possibly see an end to the epidemic if we utilize these interventions properly. So prior to exposure, people can be educated and have behavioral change, for example, using condoms, having less, decreased sexual partners, getting tested and treated for STDs frequently, and getting, of course, tested, voluntary testing for HIV routinely in primary care in clinics. And then pre-exposure prophylaxis, which is what we're talking about today, where someone can take one pill once a day and prevent themselves from getting HIV. At the point of transmission, we can use post-exposure prophylaxis if someone comes to a clinical setting within 72 hours of the exposure to HIV and start a regimen, a 28-day regimen, is adherent to that regimen, and there's a very good efficacy in using post-exposure prophylaxis among people who have HIV exposure. And after infection, when people unfortunately get infected, become infected with HIV, there are, we have made great strides in antiretrovirals for treatment of HIV and keeping people healthy who have HIV. And also by being on treatment and having a decreased viral load lowers the risk of transmission of HIV. We do know that if a person is on antiretrovirals and their viral load is undetectable, there is little to no risk of transmitting HIV to their partners. Of course, clean injection equipment has been critical in decreasing the incidence of and the prevalence of HIV in injecting drug-using populations, and we know that syringe exchange programs programs have been extremely successful. And of course, condom distribution by public health agencies has been effective. Next slide. But unfortunately, when we look at the HIV continuum, we do know that although we're doing pretty well in diagnosing people with HIV, not perfect, we have about 86% of people in this country who have HIV are aware of the HIV status. 40% of people who have HIV are engaged in care, but only 30% are virally suppressed. So that 30% are doing very well with prevention of transmission to their partners, but the 70% who are not consistently virally suppressed are more at risk of transmitting the virus. Next slide. So PrEP is an opportunity to control one's own risk of HIV acquisition, and we'll be talking a lot of detail about this, and particularly for women. So there, in the United States, there's over 1 million people who have an HIV diagnosis, but as we talked about with the continuum, there's about 500,000 who are diagnosed and not retained in care. And of those people who are not virally suppressed as a result of not being in care, they are responsible for about 60% of new infections of HIV. And there's about 50,000 people who do not know their diagnosis, who have HIV in this country, and that's a result of possibly not incorporating HIV testing into all clinical sites, which is what's recommended by the CDC, and 30% of new infections are a result of being partners with people who don't know their infection. Next slide. Next slide, please. Thank you. So what is PrEP? PrEP is pre-exposure prophylaxis. We use antiretroviral therapy to reduce the risk of HIV acquisition. The FDA approved Truvada as an agent for PrEP, an indication for PrEP in July of 2012. This is a medication, an antiretroviral medication that is used in the treatment of HIV. It is a combination of two medicines, tenofovir 300 milligrams and N-trisiptamine 200 milligrams. This is in a fixed dose combination of one pill once a day. And PrEP works is taken consistently. So taking PrEP daily is extremely important in order for it to be effective. So there are I circled two trials that were of women, that women were in these trials. The first trial, the Partners PrEP trial, remains a key efficacy study in women. This study demonstrated heterosexually active women who were in different relationships in Kenya and Uganda and were randomized to oral PrEP with tenofovir and N-trisiptamine had a 75% reduction in HIV incidence relative to those taking placebo. But among individuals in this study who had detectable blood tenofovir levels, which is an indication of medication adherence, compared to those who did not have detectable blood levels, which showed they were not adherent to the medication, but those with detectable levels had an HIV incidence reduction of 90%, which is it's an excellent efficacy. In the TDF2 study, which also was a randomized controlled trial of men and women, there was a 62% reduction in the risk of HIV acquisition and 85% among those on the drug who had high levels of tenofovir. There were two other trials that were previously done that were not successful trials, the VOICE and the FemPrEP trials, and it was using PrEP in women, and it did not show efficacy. Those trials were stopped. But subsequent analysis of these trials suggests that non-adherence was likely accounted for the poor results of these. And we've been looking very closely at why people have not been adherent to medication and how to improve adherence in clinical settings. Next slide, please. So which women could benefit from PrEP? These are from guidelines. This slide shows guidelines from the CDC, from ACOG, and from the International AIDS Society. So women who are in different partnerships where the partner may be HIV positive, Women who have infrequent condom use with partners who may be at substantial risk for HIV infection, for example, persons who may be IV drug users or who are men who have sex with men. People who are sexually active who live in high HIV prevalence areas, which is what we just discussed a couple of slides earlier. Those who have recent STIs, and those who have used PrEP at least twice in the last year. So people who have come in to ask for PrEP because they've had exposure. If they've had this twice in the last year, then they may be more at risk of getting HIV, and PrEP should be offered to them. And then I added that a woman who is trying to conceive with a male who is living with HIV, and I'll be talking about this in more detail. And the actual numbers of people who have indications for PrEP in the United States, the CDC did a mathematical modeling to look at the actual numbers who may have PrEP indications. And so MSM, men who have sex with men, and especially men of color who have sex with men, are at very high risk of getting HIV. And the CDC estimates that about 25% of all MSM in this country have an indication for PrEP. And that is estimated to be about 500,000 persons. But I want to point out that women who are have a 0.6% of all women in this country have an indication for PrEP. That number is still very high at 500,000, similar to the same number for MSM, and that we need to not forget that although there's a lower incidence of HIV in the population of women in this country, there's still a high number of women who may be at risk of getting HIV. Next slide, please. And we do know that PrEP is being prescribed, not enough, but there have been a dramatic increase in prescriptions of Truvada for PrEP in this country. This study was done by Gilead, where national electronic patient-level data was collected from 80% of U.S. retail pharmacies, and it showed that about 80,000 individuals started Truvada for PrEP over this period of time, and more recent data shows a dramatic, even more dramatic increases in the number of individuals who are starting PrEP. So that's good news. The word's getting out. Not enough. There's not enough prescriptions for PrEP, but at least we're increasing the awareness of PrEP among providers, and we're seeing a result as a result of that. There's more prescriptions being written. But who is being prescribed PrEP is a problem. This data also looked at race and gender, and we found that the majority of prescriptions that were written for Caucasian persons and not for persons of color who are at more risk of getting HIV. So it's not a reflection that who's getting PrEP is not a reflection of who's getting HIV in this country. And that education needs to occur so that providers in areas of high prevalence and areas of people of color should have access to PrEP. Next slide, please. So we talked about the fact that women who are trying to conceive, are interested in pregnancy, and have a serodiscordant, are in serodiscordant relationships, are excellent candidates for being on PrEP during the periconception period, which is the stage prior to pregnancy, when condom use may be decreased due to pregnancy attempts, and there is then, as a result, an elevated risk of HIV. Next slide. So preconception counseling in pairs should be part of routine HIV care. So I'm going to be talking to HIV providers here and women's health providers. And so providers on this call who are HIV providers should be offering prevention of unintended pregnancies and prevention of perinatal infections as a result. And should be providing counseling on all available family planning methods to those who do not desire current pregnancy, and provide methods on site. For those patients who desire children, PrEP is an additional safer conception strategy for serodiscordant couples. So in HIV clinics, we can speak to our male clients and ask if they have an interest in pregnancy, and if they do, and invite their partners to come in and talk about PrEP and offer PrEP during pregnancy attempts. In family planning and OBGYN clinics, we should be asking our patients if they know their partner's status, test them for HIV, and ask the partners to come in to be tested as well. In this, we can do risk reduction counseling to these women. We can support status disclosure if there is an HIV-positive person in the relationship, and if it's feasible to disclose HIV, we can help to support that disclosure in the clinic. We can encourage partner testing, provide information on safer conception options, and talk about the importance of antiretrovirals during pregnancy and breastfeeding to prevent perinatal transmission. The U.S. Perinatal Guidelines, which is the website is here, has much more in-depth information about how to provide periconception counseling and to women who are HIV positive. Next slide. So PrEP offers an individual control and a safe strategy to prevent sexual transmission during pregnancy attempts. It offers personal autonomy over HIV prevention. It doesn't require negotiation or a partner's knowledge of use, although we would like the partners to be aware of each other's status. If that's not feasible, if the communication isn't healthy, or if there's some abuse in the relationship, disclosure may not be something that's provided or appropriate. We do know also that during pregnancy and postpartum, acute infection that occurs during that period, where there's very high viremia, is a very high risk of transmitting HIV to the infant. So during pregnancy and breastfeeding, seroconversion is responsible for 26% of perinatal HIV transmission in this country. So it's a very risky period of time, and PrEP is a very effective way to prevent transmission to the infant if the woman's negative and the male is positive. And the U.S. CDC and WHO guidelines for women using PrEP who become pregnant recommend counseling on the risk and benefits of continued PrEP during pregnancy and during breastfeeding. Next slide, please. So what are the interventions that we can use to reduce HIV risk while attempting pregnancy? While this is a whole talk in itself, I'm just going to briefly touch on a couple items. Of course, using PrEP for the seronegative partner and antiretroviral use by the seropositive partner is very effective. Treatment of STDs and other genital infections are important because they increase the risk of HIV transmission. If the male is the negative seronegative partner and the female is positive, then she can use self-insemination of male semen, male sperm, and doing self-insemination during peak fertility period. And also the male male circumcision has been very effective in decreasing the risk of HIV to the man, and of course using the man to use PrEP if they are having unprotected or condomless sex during the periconception period. The woman is seronegative, the man seropositive, it's a little more complicated. Using PrEP and treatment as prevention is very effective in this situation. However, the woman may decide to have fertility care and assisted reproduction, which is, there are techniques that can be used, IUI, IVF, and intracytoplasmic injection along with sperm washing. However, these techniques are very expensive, may not be available, and may not be an option for our patients. So we can offer limiting condomless sex to days of peak fertility to reduce exposure, and offer PrEP and ensure that the partner who is positive is on medication and has an undetectable viral load. Next slide. We do know that Truvada has excellent safety profile among pregnant and breastfeeding women on the infant and on the fetus. Safety data from clinical trials do not indicate any likelihood of harm to the pregnancy or to infant growth when PrEP is used during the periconception period, during pregnancy, and during breastfeeding. And I have cited several articles here that you're welcome to use. Look up when you do get these slides after this presentation. Next slide. And during breastfeeding, which, as I discussed, there are high rate if there is seroconversion during breastfeeding, there's a very high risk of transmitting the virus to the infant. So using PrEP if the woman is negative and she's still at risk of getting HIV is an opportune time for her to use Truvada. To date, the only source of data from HIV seronegative women who are using tenofovir during breastfeeding is from the use of hepatitis B treatment. But we do know that during breastfeeding, there are lower levels of tenofovir in breast milk, lower than maternal serum that the infant was already exposed to during pregnancy. So during breastfeeding, there's low levels of tenofovir, and we have not seen any ill effects to the infant. Next slide. So I'm going to move on to talk about women who are not interested in pregnancy, are interested in preventing pregnancy, and how we can integrate PrEP into family planning, OBGYN, and clinics. So how we keep people to stay negative and to sex positive. Next slide. So we know that tenofovir and triciptavine do not have an effect on hormonal contraception. So there's not a drug interaction. You can look to the U.S. perinatal guidelines again that were updated in 2017. There's a great table that looked at every single antiretroviral and the interactions with hormonal contraception, and you can look there to get more information on this. But tenofovir and triciptavine has not had an effect on the contraception itself. Family planning clinics present an opportunity to integrate counseling on safer conception and HIV prevention. But unfortunately, a national survey of family planning providers had shown that less than 50% could actually define what PrEP is. So there needs to be a lot more education in family planning clinics. Couples testing has been very successful in such clinics in Africa, and we're starting to see the results of couple testing in the United States as being a way to learn partner status together in the same room, testing together, and the communications, communicating about how to prevent HIV in the future in those relationships is a very successful intervention. And of course, making environments male-friendly can promote not only male health-seeking behaviors, but also include them in engaging in preconception care or contraceptive care. Next slide. So of course, nurses know this, but I just want to review that taking a history from all patients is critical. To bring up the subject of safer sex in an open-ended way and ask permission to discuss the subject, to acknowledge that the patient most likely is ambivalent about safer sex and allow him or her to express this ambivalence in an open, trusting relationship. Rather than telling patients about why they should change to safer sex, reinforce the patient's own statements about why safer sex is a positive alternative and encourage them to repeat motivational statements. And then support patients' abilities to solve their own problems and make their own choices. So the discussions about sexual health are not just about eliminating sexual HIV transmission, but it's also about fostering sexual health and engaging with people and leveraging motivation to lead satisfying sexual lives. Next slide. And these are the 5 Ps. It's just a quick and easy way to look at how to do a sexual health history, and you can go to the CDC sites, and that's listed there. Next slide. And what can providers do to reduce sexual HIV transmission? While in family planning and OBGYN providers, they can discuss HIV vulnerability with every sexually active woman. They can present the range of prevention options, and they can become proficient in prescribing PrEP in their clinic. HIV providers, on the other hand, can familiarize themselves with reproductive health care services and provide contraception on site for their clients. And they can discuss pregnancy desires with all of their patients, men and women, cis and transgender persons. Also, HIV providers can provide PrEP to the partners of their patients. Next slide, please. So the prescribing guidelines, this is, I'm going to do a review, but this is on the CDC website. You can get a lot more information on their website that is listed right here. Very user-friendly and easy to access. Next slide. So when we initiate PrEP, we first want to assess if the patient is a candidate, if they're at risk of getting HIV. Can they adhere to a daily medication regimen? Very important to figure this out before we start PrEP. Are they willing to come to the clinic every 3 to 6 months? They must have an HIV test, and it must be negative before starting PrEP. And the reason why is that if someone is HIV positive and has seroconverted since their last HIV test, you feel like, oh, it was 2 weeks ago, I can just start PrEP now. I always get an HIV test right before I start PrEP. It is recommended by the CDC, because if someone has HIV and they're on Truvada, they're not on a regimen that's viral suppressive, and they can become resistant very easily to the Truvada. And the presence of drug resistance that is in PrEP user is a concern, because those drugs in Truvada are also used for treating HIV infection, and they're an important drug regimen in the treatment of HIV. So therefore, if a person develops resistance to one of those drugs while they are on PrEP, it can limit their treatment options for future treatment if they become infected. So it's very important to do the test at the time of initiating PrEP, and then we test every 3 months thereafter. And I'll talk about that in a minute as well. We also want to screen for STDs prior to starting PrEP. We'd like to have a creatinine clearance of greater than 60 because one of the side effects of Truvada for those whose renal function is compromised is that it can further decrease renal function. So we would like to know prior to starting PrEP if someone has compromised renal function. And then we do a creatinine clearance every 6 months to see if there's a decrease in the creatinine clearance. If the creatinine clearance is less than 60, we do not recommend starting PrEP. We also want to do a hepatitis B screen, because if someone has chronic hepatitis B, Truvada is the treatment for chronic hepatitis B, and we recommend that someone take the Truvada and stay on it. If they are not immune to hepatitis B, we offer vaccination as part of good primary care. And then we can write for Truvada once daily. Once we have these drug results, we can write for it once daily, and we don't write for more than 90 days at a time, because at 3 months we'd like to bring them back, next slide please, and do another HIV test before we make another prescription. And it's very helpful if your clinic can call patients ahead of their appointment. If they miss their appointment, if they can be called and told, come in, get an HIV test, and we'll write your prescription. We'd like to try to reduce barriers to getting Truvada, but we do need an HIV test every 3 months. We teach patients how to assess for signs of acute HIV infection and come in if they have any of these symptoms. If the patient is at risk for STIs, we can screen every 3 months, but the recommendations again would be to do STI screening every 6 months unless they have an imminent risk of STD infection at 3 months. We want to talk about adherence and side effects, and if someone is attempting pregnancy, we want to do a pregnancy test or a test for effective birth control if they do not desire pregnancy. Next slide. So at 6 months, we do the same thing I just talked about at 3 months, but we want to get a creatinine clearance every 6 months. And someone who does become pregnant and is on Truvada, we highly encourage that they report to the Antiretroviral Pregnancy Registry, which you can Google. You can call it in, you can fax in, or you can do it online. Report that you have a patient on Truvada. There's no identifying information that you give to the Antiretroviral Pregnancy Registry, and it's the only way we can really track that we can track infants who have been exposed to Truvada during pregnancy to make sure there's no teratogenic effects. So I highly encourage you to use that number if you have a woman who's pregnant on Truvada. Next slide. And if a patient wants to stop PrEP because they're no longer at risk of getting HIV, we call this seasons of vulnerability, that during one's lifetime there are different seasons where they may be vulnerable to HIV. When they're not vulnerable to HIV, then it would be a time that they can stop taking PrEP, and they can be started if they're at risk of getting HIV in the future. So we want to talk about reasons for discontinuing, and we want to talk about safe sex counseling, and also that if they are at risk of getting HIV in the future, to come back to the clinic before they start Truvada again and get an HIV test and get the screening done and have a provider provide PrEP on site. But it's very important, again, to get an HIV test before restarting Truvada. And if a patient has chronic hepatitis B, and we do recommend they continue Truvada for hepatitis B treatment, but if they stop Truvada, we would like to monitor their LFTs for a liver flare. Next slide. So there's a lot of discussion lately about how long the time to protection, when is the steady state levels of Truvada and M-trisiptazine in different tissues. So we do know that in rectal tissue, there's a good penetration after 7 days of being on Truvada. So we recommend that people who are having anal sex to use condoms for 7 days after they've been on Truvada for 7 days, and then if they are deciding to not use condoms, that would be a time to stop. For cervical vaginal tissue, the CDC recommends that we wait 20 days, that we tell our patients to use condoms for 20 days. However, there is laboratory research that shows that there may be earlier penetration, steady state penetration in the cervical vaginal tissue as early as 7 days, and we're just waiting for more studies to occur to change these recommendations. But there may be good efficacy, good penetration at 7 days in cervical vaginal tissue as well. And blood levels are, again, 20 days before there's adequate blood level, before there's adequate steady state levels of Truvada and M-trisiptazine in blood levels in serum. Next slide. These are the billing codes that you can use. This is on the ANAC website if you'd like to go to remind yourself what the billing codes are. And again, it's on the slides that you'll get mailed to you when this webinar is done. Next slide. So I'd like to end with talking about the nurse's role in PrEP for women. Next slide. So nurses can play a critical role in PrEP implementation. We do know that brief counseling from a trusted healthcare provider has demonstrated a positive impact on safer sexual behaviors. That if we counsel patients and their partners about HIV and STD prevention strategies, if we link any STD testing and treatment with PrEP provision, that we can make an impact, and nurses are in a perfect position to be able to do this. And HIV treating nurses are also in an ideal position to have these discussions, to talk to patients about that it's vital to their health, it's vital to their partner's health, and to the community in decreasing the incidence of HIV if PrEP is used. Next slide. And nurses can be leaders and advocates for change and can play a very important role in PrEP rollout. So programs must provide easy access to PrEP with providers who are knowledgeable about PrEP. And nurses can become the experts in educating, prescribing, and monitoring PrEP in the clinical setting. Nurses can help build capacity of the healthcare team in implementing PrEP. In Ryan White programs, Nurses can be creative in setting up parallel PrEP programs for partners of their patients, can help find sources of prevention funding for PrEP services, ensure that insurance reimbursements are not a barrier to care, and can help advertise availability for PrEP for women. Sorry, my computer just blacked out. So, excuse me for 1 second. So nurses can be advocates for patients and for creating change in helping to eliminate the incidence of PrEP in this country. And that I really want to thank each of you for your interest in this topic, encourage you to help and encourage you to help end the HIV epidemic through the information that was provided in this webinar. So thank you very much.
Thanks, Erica. Sorry about that little technical difficulty at the end.
Yeah, that's fine. I'm back.
Okay, I can finish. There's a few more slides if you'd like me to finish them for you.
Yeah, if you could, please, that would be helpful. Thank you.
So one of the things that Erica provided us with information about is strategies to increase women's knowledge about PrEP. That clearly integrating post-text HIV counseling with information about PrEP and PEP is advisable. Ask all, as she has described earlier in the presentation, ask all pregnant women about their partner status and offering HIV testing to partners and expanded in prenatal GYN and family planning clinics. That HIV clinics should educate patients and their partners about PrEP, and when feasible, offer PrEP within HIV clinics. Another way to empower women is to build adherence programs, especially for younger women who are on PrEP, and again, to integrate PrEP with HIV testing, STI testing, pregnancy testing. That was your last slide. So the technical difficulty only was for one little slide. So
okay, I really great. Thank you.
Yeah, I really want to thank Erica for this great presentation. I learned a lot. She really went deep into some of the issues around PrEP and women. It's really, Erica's an ANAC member. It's really wonderful to be able to tap into the expertise of ANAC members, and I was also really happy to see the number of citations to JANIC, to the Journal of the Association of Nurses in AIDS Care. So thank you, Erica, so much for this presentation.
Thank you.
Before we move into questions, and I would encourage you, we have some questions in the chat box already, to please, under the questions section on your sidebar, please type in questions and we'll get to them. We have time for questions. But we do want to provide for you this series of PrEP resources. Our ANAC website has a PrEP page under it, under resources, and then on the top bar, there's a section for resources, and then if you go under there, there's a PrEP page. That's a living page. In fact, we're constantly updating it. After the last two webinars, both today's on women and the one 2 weeks ago on PrEP for Black gay men, we have new information to update on the ANAC website. But if you go on that website, if you go on our website, there's numerous links and resources and links to other sites around PrEP. One of the things that we will be adding today is the link to the HIVE website. So HIVE is a coalition of organizations, providers, advocates, primarily out of San Francisco, looking at PrEP for women. Erica, do you want to spend a minute talking about HIVE? I think it's a great segue. It's a great connection for this website, for this webinar. I'm sorry.
Yeah, HIVE has paid a lot of attention to sexual health for men and women. There's a site on there for men who are interested in, who are HIV positive or HIV negative, who are interested in pregnancy with HIV positive or negative women. There's a lot on PrEP, on how to get pregnant safely. There's an online chat room for people who are at risk of getting HIV or women who have HIV. And they've really been a great resource for all of us clinically. In the clinic, it's a great site to have on your computer that you can show people. There's wonderful videos for women, and then on the website. And I think it's a great site to become familiar with.
Great, thank you. There'll be links again on our website. We'll update that to have the Hive and the Please Prep Me. There are many other links on our website, including to the CDC guidelines and also information about the PrEP line. That's run out of UCSF. Many nurse practitioners are staffing that PrEP line. It's really meant to be it's a case consultation line, right? So if you have a patient that you're considering starting on PrEP or are on PrEP and you need some peer-to-peer consultation with a PrEP expert, this is a case consultation PrEP line. You'll see the information there. And then the other thing we really want to point out is the PrEP locator. Again, you can Google it. You'll get this set of slides, or the link to it is on our website. That's a interactive map where you put in your zip code or your patient zip code, and it'll come up with all of the closest PrEP providers. Just a little heads up to those of you who are PrEP prescribers in our audience. We've asked before, and we'll continue to ask, if you are a PrEP prescriber, we encourage you to have yourself listed on that PrEP locator site. So there's a place when you go there that you can list your information. We encourage you to do that. So we are now going to have time for questions, and we have quite a number of them. Let's see. Wow, we have a lot. Some of them are related to, two of them are sort of the same. They're related to the intersection between the positive partner having an undetectable viral load, and the woman for PrEPception, for example, being on PrEP. So let me read these questions. In these studies, when you're looking at the efficacy on PrEP adherence, was it about PrEP only, or were positive partners also with undetectable viral load? And I believe the next question is the same. Yeah, so my understanding, and Erica, please correct me if I'm wrong, is that the PrEP studies were studies of PrEP alone. They weren't with couples where the positive person was on with undetectable viral load. They were looking at the efficacy of PrEP and without regard to the regard to the potential sex partner's undetectable viral load. Is that correct? The goal of the study was to have the partners be on antiretrovirals and have an undetectable viral load, but it wasn't an exclusion to the studies if the partner was not undetectable. But there have been demonstration projects since that time in the United States that look at PrEP in clinical settings, and we've seen that PrEP is very, very effective even if the partner does not have an undetectable viral load. The goal, though, is for the partner to be on ART and have an undetectable viral load. That's the goal. Of course, there are couples where the woman may suspect that the partner's on HIV positive but doesn't know if he is, or that he is not taking antiretrovirals. It's still very important for her to be on PrEP, and it is efficacious. There's another question about age limit. Is there an age limit to start PrEP medications?
There's no age limit, no. You can start PrEP at any time in your life, except, I'm sorry, the FDA, it's approved by the FDA for 18 and over. So there are adolescent clinics that are using PrEP and are prescribing PrEP for those under 18, and it's been efficacious in those clinical settings, but the FDA has only approved it for 18 and over.
Right. So I know that one of the intersections here is sometimes if something is not FDA approved, then there may be problems with insurance, right? So even though we know that we do know that the ATN, the Adolescent Trials Network, has done a number of research studies on PrEP use under 18, and that the efficacy and safety is looking the same. One of the challenges that we're aware of in the community is concerns that those who are under 18 may not have insurance for PrEP. In addition to the fact that they're on their parents' insurance, and they don't want their parents to know that they're on PrEP, that may be an issue. So there are some intricacies around PrEP for patients under 18, but it's really mostly related to coverage and insurance. Again, I think that's something that you could use the PrEP locator for if you have questions about someone who might be providing PrEP for adolescents, and we're talking about we're talking about PrEP in women, and so therefore PrEP in young women.
I just want to also point out, Carol, that if someone has no insurance, if they're not on their parents' insurance plan and they have no insurance, Gilead does have a patient assistance program that can provide PrEP to those not on insurance, and there's not an age limit on that using the patient assistance program.
Great, thank you. That's actually another question about are there funding sources for PrEP? We actually will have that information on our website from a previous webinar, and we'll make sure that that is highlighted as we do our update from the last two modules, that the various patient assistance programs that patients may be eligible to apply for are there. I also would encourage you, if you do have these questions, we did have a past webinar last year entirely on the insurance and financial and patient assistance programs. So we'll make sure that you have access, that is highlighted on our website. It's in there, but it just may be deep in there for all that information, because that was another question.
But just something that's just a quick answer to that is if you go to Truvada.com, then there's at that point you can go to PrEP for providers, and you can go to the patient assistance form. That can be filled out quite easily in your clinic. It can be sent back to the pharmacy, to the patient assistance program, and Truvada will then be delivered to the patient's home. And every 6 months that has to be that form needs to be redone. It's not very hard to do, and if the patient has no insurance, that they can get that. This is very accessible to them. Also, that same patient assistance program does cover $3,600 for co-pays per year, and that's something that's very easy to get right on the website.
So I do say here is another issue that we all struggle with, and I think this is a role for nurses as advocates and for health system leaders. And I'm going to read this question directly. Our biggest problem is getting partner assistants to pay for their care if they have no resources. The patient assistance programs can cover the med, but I don't know what the OB stands for. OB, I guess, and the labs are not. Office visit, but the office visit and the labs are not covered. That is a problem. We know that is a challenge. We know that Ryan White programs by law are limited to providing services to HIV positive people, and so Ryan White programs are encouraged to think of using other funding sources. So if they have any other community funding, if they have any other sources of funding, any discretionary income that they can use to cover the office visit and labs to provide PrEP within their clinic. They certainly have the expertise and the setup to provide it. They can get the medication from the patient assistance program, but there is that gap for underinsured and uninsured. How are the office visits and the labs not covered? And this is a role that ANAC has taken on as an advocate. We would encourage those of you who are facing these issues in your own clinical practice to get in touch with us, and we can figure out how to amplify our voices and figure out a way to think about how do we get the full complement of services, office visit and labs, covered for those who don't have insurance or are only covered by Ryan White and the limitations there. So it is still an ongoing issue. again, nurses as leaders of health systems and patient advocates hopefully will play a role in turning this corner and getting the other services covered.
Also, I just wanted to point out also that although it's not complete, the patient assistance program does cover hepatitis B testing for free and HIV testing for free. And the Office of Population Affairs is looking at and planning for how family planning clinics can cover PrEP.
I think we just got a correction in the chat box, and I believe that we need to make this correction. The Gilead Medical Assistance Program is only open to persons over 18 or older.
Oh, okay. Thank you. Thank you for that.
Okay, here's a question. I train providers on PrEP, and one question that often comes up when discussing PrEP in women is that women often don't know the HIV status or risk profile of their male partners. How do you assess risk and determine who can benefit from PrEP in your own practice with these restrictions?
Well, that's a really good question. I feel like taking a good sexual history and asking the woman if she's worried about getting HIV, if she feels that she's at risk, if she doesn't know the HIV status of her partner, if she's worried about the partner having other partners, that at that point PrEP comes into the conversation. It may not be exactly what she wants. It may not be that she's at a high risk for getting HIV, but the fact that she knows about PrEP, I think is very important for us to educate people so that at least she knows that, that in the future, if she's not ready now, in the future, if she feels that she's at risk, it's something she can come back for. But I think, the fact that if someone lives in a high prevalence neighborhood and is having, is not using condoms consistently and is worried about getting HIV, they would be a candidate for PrEP. And if they feel that they want PrEP, I do not turn people away. I know other providers may feel differently than I do about it, but I feel like it's something a woman really needs to decide herself what her risk factors are. And if she's uncomfortable, PrEP could be excellent for her. So I think getting a good sexual history and having a good discussion with her about these risks are the beginning of that, of uncovering her risks.
That actually brings up a question that came up about resources for sexual health history, taking more information on the 5 Ps. Again, you will receive this slide deck yourself so that you can then look at where those sources of information came from. You'll receive that slide deck in an email following this presentation. So you can really look at those sources. And then again, on our website, we do have some information there, and we will highlight some of the sexual health history taking resources and tools. We've heard 2 questions about that in the chat box. So this is actually very helpful for us to also understand what are some of the parts to our resource page that need to be highlighted.
And the five Ps were adapted from a guide to taking a sexual history by the CDC. It's on the CDC website. Go ahead, Tom.
I'm actually going to pull that up while we're talking. Let's see. How many times can someone get PEP, post-exposure prophylaxis?
Well, that's a great question. So the guidelines basically say that if someone has more than 2 uses of PEP in 1-year period of time, that they're at risk of getting HIV, and they are good candidates for PrEP. And you can transition someone from taking PrEP to taking PrEP. So someone who's finished their 28 days, they can stop the 3-drug regimen that is used for PrEP and then just transition to taking the Truvada portion of that regimen daily for PrEP. There's no limit on how often someone can get PEP. However, if someone is coming in frequently, and again, more than 2 in 1 year, then high recommendations are that that person start PrEP. But please keep in mind that you can transition them so that there's no days of no coverage. You can keep coverage daily that way.
So I'm going to close with one final question, and then we have a number of questions that we haven't answered that we will, what we do on webinars when we have unanswered questions is we send around a sort of like an FAQ page. So the questions that were entered into the chat box that weren't answered, we'll send you around those questions with the answer. But the final question that we'll cover today is, I work in a family planning clinic. Most of the patients come in for STDs. While this is a good time for PrEP, we don't offer it. What can we do?
So that's a great question. And I strongly believe, and so do others, through lots of studies that have been done on the fact that if you have been exposed to an STD, if you get an STD test and you are getting STD treatment, that you're at risk of getting HIV and that you should be offered PrEP. PrEP should be coupled in family planning settings with HIV, people who come in for an HIV test, people who come in for STD treatment or testing, people who come in for pregnancy tests, and people who may be on a LARC and not a long-acting contraception and are not using condoms. These would all be people in this family planning setting that you could discuss PrEP with. And again, if persons aren't interested in PrEP, then they can at least know that this is something they can come back for. If you are not providing PrEP at your clinic, you can go to the PrEP locator and help the patient find a PrEP provider near your clinic, or you can institute PrEP at your clinic. And the nurse's role as a patient advocate and educator, you're in a perfect position to start to institute PrEP in your clinic. You can go to the PrEP guidelines, and there's lots of information on the CDC website, patient information, provider information, and you can start to do this at your site yourself. Thank you,
Erica. I do want to remind folks of the PrEP locator. While we are struggling with setting up PrEP programs in or prescribing PrEP within our own clinics, including figuring out the way to pay for office visits and labs, the way to use the patient assistance program. We have heard of patients becoming HIV positive while they are waiting for PrEP programs to be set up. Real patients, right? So I would encourage you to become very familiar with the PrEP locator so that you can refer patients directly to a PrEP provider and make a relationship with that PrEP provider so that you can have a warm handoff and a real connection. When somebody comes asking for PrEP or has a scenario that requires PrEP, it's our responsibility to make sure that they have that education and that information if needed. So thank you all so much for participating. This brings us to the end of our time. Again, you'll get the slides, you'll get the link to do the CNE, and you'll also get the FAQs for the questions. There's probably about 8 questions and comments that we weren't able to get to. Thank you, Erica, so much, and this concludes our webinar for today. Goodbye.